All right, we'll go ahead and get started. This morning we're going to hear about enhanced recovery after colorectal surgery with Triumvirate, who will be presenting the data and the information to us, because this really is a team effort, and so it's important to recognize that. We're going to hear from Dr. Samir Gandhi, an assistant professor in the Department of Anesthesia who completed a residency at UT Houston and a fellowship in oncologic anesthesia, who's helped with development of ERAS protocols both at MD Anderson and here, who's a board-certified anesthesiologist, who's also certified by the American Board of Medical Quality and serves on our Perioperative Quality Improvement Committee. We're here from Christy Hill Herrera. Most of you know Christy. Christy works in quality improvement here with our hospital, and she's overseeing the American College of Cardiology Registry for Interventional Cardiology, and works with Dr. Stewart and Dr. Jenkins very closely on our NSQIP, the National Surgery Quality Improvement Program Registry for Surgery, and has actually worked with us and some residents on some projects for the residents as well. And then starting off the presentation will be our very own Dr. Dow, who's a graduate of medical school in Valencia, Venezuela, who trained in surgery there, then came to the United States, trained in surgery again at St. Elizabeth Medical Center, which is affiliated with Tufts. He did a colorectal surgery fellowship at Brown, joined the faculty back at St. Elizabeth's at Tufts for several years, and then we were fortunate enough to recruit him down here a couple of years ago to join our faculty. He's been doing some great things for us. So Dr. Dow is going to start it off for the group. Thank you.
Well, good morning. Thank you for having me again here. We're going to talk about a little bit about what ERAS is and what are we doing here at the University Hospital and with UT and our practice. And basically, I'm going to go over what the evidence is. This is not something we're making up. This is not something new, but it's something it's going to be new to us, the way things are happening at the university. So I have no disclosures. And there's many definitions, but the one that I like the most came out in 2012, which is a multimodal pathway that we want to implement in our patients to reduce their stress through, as much as possible, pain-free procedures with less organ dysfunction, less morbidity, and improved recovery. And that might mean many things. And while I'm defining this, I want to make clear that, even though we talk about colorectal ERAS, colon surgery and rectal surgery are two completely different things in terms of recovery and what to expect the patients will do. We're trying to lump them together, and with some things will cross over, but there's really a rectal enhanced program and a colon enhanced program in terms of recovery, because it's not the same doing a right colectomy on a patient, expect them to go home on day 2, that do a proctectomy on a patient and expect them to go home on day 2. That really rarely happens. So, although we like to think we're special and we started this, we really didn't. So there's a colorectal surgeons ERAS, and hepatobiliary surgeons have their own set of ERAS protocols, as well vascular, thoracics, and orthopedic surgeons. And all these have been proven successful through the years, and they involve different interventions that might not apply to what we do. So where do we start this, and why did someone in Denmark start saying we should do something about this? Well, this is the Leahy Clinic experience, and they published this paper 20 years ago. This is the length of a stay of patients in the 80s and 90s. These patients will used to come to the hospital the day before or 2 days before to get prep. They will stay anywhere from 8 to 14 days post-op after regular elective colectomies with an NG tube. We were waiting for them to pass gas before they went home. If they didn't have a bowel movement, they were not fed. We starved them preoperatively, and hence they stay there forever. This is what the numbers look like. If you got a right colectomy, you stay there 9 days. These are all open procedures. This is like pre-90s laparoscopic adoption of colon surgery. If you got a left colectomy, 8.5 days, which might seem surprising, but I have found that right colons get more ileus than left colectomies for whatever reason post-op. And if you got a stoma, you're there for 2 weeks. We, at some point, ran the numbers using a nationwide inpatient sample, and this is our length of stay. This is 9 years ago. This is not new data, but it hasn't changed much since the last time I checked it. Right colons used to stay 5 days on average in the country in the hospital. If you do it laparoscopically, 6 days you do it open. The same goes for sigmoids and open sigmoidectomy. So 4 to 6 days for elective procedures or laparoscopically. And these are the costs or the charges, not necessarily the cost. So you stay 3 days in the hospital for a lap sigmoid, you spend probably $30,000 of $2,009. If you stay 7 days, that goes to $55,000. And you can see what happens with open cases. It's more expensive if you stay more in the hospital. So in 1995, this group from Denmark realized that they need to do something about it. And they involved patients that we would normally not qualify for this. Only 8 patients. They were for stress-free colon resections. These were all sick people with ASA 3 or above, and they thought that if they stress less, they would do better. This is kind of the opposite of what we're doing now. We're getting people with ASA 3 or less to do enhanced recovery after surgery. So they tried to do laparoscopy. They put epidurals on all these patients, give them food early, and get them out of bed. So all these patients went home as expected in less than 2 or 3 days. This is in Europe, which probably still the length of stay of these patients is 7 days, since they have no rush of getting people out of the hospital. And they ended up concluding that if we use an aggressive perioperative care, and they elaborate in further papers what they would do. This is like a page and a half at the Lancet, not even a full report. Things would happen and people would actually leave the hospital in a good state, feeling better, and with less complications. So they published this a few years later, and the same group, and they say what the pathway was to enhance the recovery of these patients. And of all comers, they divided people who would not be able to get a 2-day length of stay for different reasons, either for preoperative findings or intraoperative findings. You know, things like invading the duodenum or someone has a stroke pre-op or these kind of things. But what they realized is that most people, which is group C, were able to leave as planned within 2 days of being admitted to the hospital. And just very few people will have an absolute contraindication or absolute trouble to stay, and they will need to stay in the hospital for more time than they would plan to. And when you center perioperative care and put all these measures around it, this is when things will happen. And I'll go over the evidence that doing isolated measures will not help at all developing an ARDS protocol. So we focus the interventions in phases, and you have to pre-op phase, intra-op phase, and what we do post-op. They're equally important. And this is like the skeleton or frame for this. It starts pre-op right here. It goes about the counseling. And there's some controversial things here, like no bowel prep. Now, still debate out there about bowel prep or no bowel prep. Most of the new randomized controlled trials say that even though they have no influence on length of stay, they do have an influence in SSI, and we are embracing bowel preps here for all our patients for that reason. So 2 different things. Yes, they will have a bowel movement sooner if you don't prep their colons, but we think now with the evidence we have, again, we had it before, but now we kind of readdress the data, that they will less get surgical site infections. And with the new anesthesia techniques that Dr. Gandhi will talk about, giving blocks and expert and long-acting local anesthetic agents, the role of mid-thoracic epidural anesthesias might not be as strong as they describe on their paper. Nowadays, with laparoscopic surgery and a TAP block, these patients are basically pain-free with no PCAs on day 0 after their surgery. But it's multiple things, and they're very important, all of them. And the goal is to slowly transition the patients from their intraoperative state to their homes in the safest and best way possible. But as soon as these start coming out on the report, it was clear that just having a protocol in place was not enough to get this visual. And people start breaking components to see what fit their hospitals or what fit their practices. And it was very clear that when that happened, things did not happen. Out of that experience, this group published what they think is the most important things, and all they're highlighted here, is basically getting the patients out of bed early, feeding them early, don't overload them with fluids, and if possible, get the Foley catheter out. If you do these things, those have the most influence in the overall outcomes of your ERAS protocol. And more papers came out about adherence, and it was clear that if you do 100% of the measures that you were supposed to do, your readmissions will be optimistically zero. I'm not sure if that is achievable in our practice here, but it will be lower. And the length of stay will go down as you implement more measures and your compliance goes up, as well as your morbidity and mortality will be significantly down for what it would be to implement, not even half, less than 65% of the measures. So now that we know that doing everything or as much as possible is important, this group of researchers asked themselves, what about if we do more than 90% instead of 60 to 80%, which 80% is ideal? Will be doing more or do better compliance equal better outcomes on these patients that we are overachieving to get more measures in? So they got 251 patients, and they divided by compliance in terms of, like, if you do less than 70, 70 to 90, or you will go more than 90% compliance. And they saw that the more compliance, the length of a stay will steadily go down from 6 to 4 to 3 days, meaning statistically significant. Your morbidity went significantly down from 35% to 16%, and your readmission rate rose from 8.6% to 6.9%. Not statistically significant, but they don't elaborate on the cause of readmissions and whatnot, but all the rest changes. So with that in mind, we are trying to answer the question, which of these factors have the strongest association with a prolonged length of stay, morbidity, and readmission in these patients? So, and the number one factor is low compliance. And I can't stress this enough because there's many people taking care of these patients. It's not just me in the operating room. It's the residents who's overnight who might not be involved with this case. That's why educating is so important throughout the ranks, so we're all in the same page. If one of the chain, links of the chain falls apart, then the whole protocol, it's not gonna work as expected. So don't getting the patients out of bed, delaying their oral intake, keeping them Foley in, don't give an IV fluid restriction and starve them long, and you'll have the patients here for a week. And this is surgical endoscopy. Just came out with this in April, and it's a very nice graphic. As you compliant lines go up, your complications go down, and it's a linear relationship almost in terms of the more you do and when you do things well, it's expected that these patients will have less complications and go home early. So, since we work in a teaching hospital, what barriers are there from a resident standpoint to implement these ERAs? And this was done in Canada, which is not that much different from our system of practice here. So when they asked the residents how comfortable they would feel like sending, for example, an LAR home on day 3, less than 40% will say, I'm confident that this patient will do well at home. Open colectomy, junior residents, 20% of them said, yeah, they will be fine at home day 2 or day 3 after surgery. So lap colectomy, most people felt confident that these patients could go home earlier. But still you see that even though it's proven that open surgery through an enhanced recovery program is safe, we're still training residents to think that it might not be safe to send them home early. And when they ask them, why do you think this would be? And there's many factors there, but from patients, surgeons, or residents, people don't feel it's safe. It's, big surgery equals long length of a stay. Some surgeons don't believe in ERAS, and they never have, and probably they never will. There's dogma, expectations from the family. So multiple things we need to intervene. That's why education in multiple phases of this protocol is so important. So they found the same problem in New Zealand and Australia. This is not just a North American problem. So only 19% or 29% of survey surgeons or MDs involved in this patient said there's no barriers. Everyone else found a reason why not to do this. And in order to improve compliance, this group, the same group I presented with the resident perspective in Canada, came out with this paper about what to do to implement this safety and to implement ERAS protocol in a safety way. And they found that the best way is to identify champions within the teams to push this forward and to educate and have everyone on board and explain why is this so important. And that's basically to go over that feeding patients is probably safe, getting them out of bed, how important is to the fluid management of the patients, and coordinate between the services. And it's all education-based. So the barriers that are usually presented are like if you feed someone else, so you feed a patient early, they're going to get an ileus, and we think that, probably nursing thinks that as well, which is a big part of the care on the floors. If we use a lot of things to keep them comfortable, they might not wake up. It's too hard, that we have no resources, it will never work here. Those are the comments that they made throughout the paper. But if we establish a team relationship and coordination, these are the key elements of us rolling this out here. So now from where Dr. McLeod practiced in Canada, huge teaching facility, we moved to a huge teaching facility here in a safety net hospital in Houston, probably no different than our hospital. This is led by Dr. Cow here, who is a trauma surgeon, I believe. And they wanted to identify what barriers they had in that kind of practice in terms of implementing and rolling this out. So they wanted to identify what barriers they were. They interviewed MDs, RNs, and patients. And they found that the positive factors were that we all wanted a standardized care. We thought teamwork was important, and patient care was the center of all what we were doing. But the barriers they identified were that it involved a practice change for most of us, which we were not comfortable with. Coordination, even though it sounds nice, is not easy to do. The patient population they were treating, they didn't think it was fit for most of these enhanced recovery procedures. The resources, this is an expensive thing to roll out, but then it will pay at the end. And having different residents in the service at different time of the day, definitely it's a handicap for recovering these patients the way we are trying to. But overall, most people had a positive perception of this and wanted to roll this out at the hospital. So having said that, and I'm almost done with my part. So this is where we are. This is what we're doing here. And we think that linking ERAS with the SSI bundles and the colon bundle protocol that already roll out here will lead to better outcome for our patients. Maybe this is the goal. I'm not sure we're going to achieve it, but it's been described. And we have to be open to change. We have to be willing to train the staff and educate our patients and put the time to do so, and have a mechanism to enforce compliance of these measures. But, and to wrap this up, we know now ERAS is safe. Nothing's going to happen because you feed a patient that can't be fed on day 0 or day 1. It's not an isolated effort. If we don't involve every part of the team, this won't roll out, regardless of what our wishes are. We need to standardize procedures. We all have strong feelings about different things, but if we don't get this standardized and we do the same every time, it won't work. And if we do that, we are going to decrease our length of stay, complications, and overall costs. Oh, thank you.
I guess thank you for inviting me to speak to you guys this morning. My name's Samir Gandhi, and thank you for the introduction earlier. So I'm just here to kind of tell you what to expect from your anesthesiologist for when we start implementing some of the protocols for the enhanced recovery after surgery. Oop. It's not what I meant to hit. I have no disclosures to tell you about. So what is ERAS? And I think Dr. Dow already kind of told you about that. And I just put up a little definition there also. So it's a collaborative, multidisciplinary, perioperative strategy for integrating evidence-based knowledge into clinical practice with the goal of expediting recovery after surgery. And as he told you, I mean, I've helped develop protocols for multiple different service lines. We're starting with colorectal surgery here because that's kind of one of the ones that it's been practiced and tried on it in that patient group. So what are some of the critical components? Patient selection, I know Dr. Dow touched on this already, and one of the most important things is being able to educate your patient on what is expected in the protocol, optimizing pre-op nutrition with carbohydrate loading, opiate-sparing analgesia with an emphasis on multimodal techniques, optimizing fluid administration, and then early feeding and ambulation, and along with that, the early removal of tubes and drains. And all of this is for early functional recovery and ultimately a decreased length of stay. So for patient selection, some of the factors to consider when you guys are thinking about who do you want to implement an ERAS protocol in is patients that want to be and are active partners in their own care. They should have a supportive social structure that will aid in this kind of functional recovery. So, friends and family that are around that kind of help them define the expectations and can help them with what the education that we're providing them. Demographics to consider, such as language barriers and lower education levels that will hinder the ability to understand and implement the protocols. Complex patients, as he said, we're doing ASA 3 and lower. So patients that have a high level of comorbidity or advanced disease shouldn't really be candidates for this because it's really going to be hard to prove that what we're doing here is effective in that we're able to reduce length of stays. And then patient expectations, that kind of goes hand in hand with their being active partners in what we're implementing here. So their preconceived notions of recovery and our ability to define their expectations. So one of the biggest shifts that will be occurring, and especially from the anesthesiologist perspective, is the whole NPO time. And we'll be working with our department to kind of shift those expectations. So a review of 22 randomized control trials comparing the different perioperative fasting regimens and associated complications showed there's no evidence to suggest a shortened fluid fast increased the risk of aspiration. And obviously that's kind of what we're always concerned about when we're asking for a 6 to 8 hour NPO time. So our ASA NPO guidelines state that for clear liquids, it's a 2 hour NPO time, and for solids, it's 6 to 8 hours, depending on the amount of consumption. So what we're going to be doing is ensure pre-surgery, which is a clear carbohydrate drink. It's a 10-ounce bottle. It'll be given to them in our anesthesia clinic. And I think we still need to determine if we're asking them to drink one the night before surgery and the morning of, or just the morning of. And they'll be drinking it. We're going to ask them to drink it just before they leave for the hospital. So by the time they check in and they're in holding, it'll be about 2 hours. And this will be contraindicated for severe reflux or gastroparesis. Multimodal analgesia with an emphasis on opiate-sparing techniques. This is something we kind of try to do always anyway, but here's kind of the rundown of what we'll be trying to implement in a standardized fashion. Preemptive PO analgesia in the pre-op holding area, so we'll be using naproxen 500 milligrams. We'll avoid this in renal insufficiency. Gabapentin 600, avoid in somnolence and in the elderly patients. And that's kind of a relative thing in that you could have a 60-year-old that looks like a physiologic age of 80 and vice versa. So, I mean, we say 70, but you can use your judgment if they're a very active 70-year-old, then you can still use it. And I guess that'll be a discussion between the surgeon and the anesthesiologist as well. Tramadol, 50 milligrams, avoid in the elderly as well. And then a note for you guys and for us, when we do these PO meds, we'll really try to delay placing, or rather at least suctioning the NG tube to allow time for absorption. Intraoperatively, would like to consider regional anesthesia, either an epidural or a tap block, depending on the type of surgery. Obviously, if it's open, we would prefer an epidural. Tap blocks work great for laparoscopic surgeries. You really can avoid using the reflexive action of putting on a narcotic PCA postoperatively with a lot of those patients. They tend to give you a level of around T9 or so. So any lower abdominal incision is covered well by them. Acetaminophen IV at induction, and we can plan to redose this Q6 for the first 24 hours, and the max dose will be 4 grams per day. And then we'll consider IV ketamine in pretty much every patient, and that's kind of something that most anesthesiologists think about right now anyway. And then if they don't qualify for any regional technique, or there's some kind of contraindication, then we'll ask the surgeon to infiltrate the surgical site incision with liposomal bupivacaine, which is a formulation of bupivacaine that's long-acting, lasts for about 72 to 96 hours. Vigilant glucose management, this is really just a tweak from what our current practice is. We're reducing, we really don't think about giving insulin until they hit 200. So we're asking for a little bit tighter control, and the target range will be 100 to 180. For uncontrolled diabetics, we can leave it to the discretion of the anesthesiologist, but ideally maintain levels below 200, which is our current practice anyway. But a note for who's going into this protocol, patients that are severely uncontrolled diabetics really shouldn't be considered for this anyway, because you'd expect their disease burden to be higher and their length of stay to be increased just because of that. So it's really not going to be a patient you'd want to put into this pathway anyway. Hemodynamic optimization, this is something Dr. Dow mentioned as well. Our goal here is to minimize IV fluid therapy with using goal-directed fluid therapy. We won't be chasing urine output, which is sometimes people's current practice. And then outside of any primary considerations for fluid management, such as acute blood loss, CHF, how we deliver fluids in liver surgeries, our goal would be to titrate to a stroke volume variation of 8 to 12% by using a cardiac output monitor, either a flow track or a clear site. And the goal of all this is to just avoid excessive fluid and water administration. And this goes for us intraoperatively and when they go to the floor. For residents that are managing them, really try to think about if they need a fluid bolus before giving it to them. PONV prophylaxis, again, this is something we always routinely think of. The only slight changes, we'll ask that every patient receive a dual agent chemoprophylaxis, with our options being Zofran 4 milligrams IV prior to emergence, which is pretty much a common practice for us. This is avoided in QT prolongation. Scopolamine transdermal patch to be applied in pre-op holding, which is a fairly common practice for us for patients that are at high risk for PONV. This can be used in any patient that's 18 to 70 without a history of closed angle glaucoma. Dexamethasone IV 8 milligrams after induction, and then relative contraindication in diabetics and people with poor glucose tolerance. Amend 125 PO is a relatively new drug. It is pretty expensive. It's it's traditionally been used in patients that get chemotherapy-induced nausea and vomiting, but it works very well. It's a neurokinin-1 inhibitor, and really ask that you only consider the use of this in the highest risk patients because of how much it costs. And then Phenergan 6.25 IV for rescue and PACU, which is also a commonly used practice for our department. Normothermia, not much of a change there from what our current practice is as well, but it is one of the critical components of ERAS, and we will be looking at it for compliance for these protocols. So the optimal temperature range, 36 to 37.4. The slight change in what we will be doing is using a temperature-enabled Foley catheter for accurate core body temperature measurement. And then the active rewarming measures that we use are the use of a bear hugger, which is fairly universal, the use of IV fluids via hotline, and then the use of a humid vent for heat and moisture preservations. And if all else fails, sorry for the surgeons, but we will be warming the operating room at that point. DVT prophylaxis, again, a slight change in our practice here. TEDS SCDs, which are commonly used as anyway. We will start doing heparin 5000 sub-Q, kind of the same DVT prophylaxis that you guys already use on the floor. For patients that have an epidural, our generally accepted practice is to wait 1 hour after the placement of the epidural. However, we'll leave this to the discretion of the anesthesiologist, but we do ask that at some point they give them the 5,000 of sub-Q heparin. And then the DVT prophylaxis on the floor can continue however you guys normally manage it, and our acute pain team for the patients that have an epidural will coordinate the removal of the epidural. And that's really all I have for you. Those are the critical components we'll be looking at. The protocols are coming. They're not meant to kind of create protocolized medicine, but these critical components that we're talking about have been shown to work. They are evidence-based, and but they do remain flexible in that, we want input because everyone obviously has a different surgical population. Thank you. And I think Christy will talk about the nursing aspect of it.
Are you going to be able to stay for a little bit for questions? Thank you. Mm-hmm. Good morning. Sorry. I apologize, I had this loaded, but it doesn't want to open. I'm just going to talk a little bit about where we've been and where we're headed. I know that several of you that have been involved are probably thinking this has taken forever, and we've been working on it for several months, as Dr. Dow and Dr. Gandhi and Dr. Wallish can attest. But we want to make sure that we have things in place. I appreciate the help of the nursing staff, pre-op, PACU, 10th floor. Is anybody from 10th floor here this morning? Yay, thank you for coming. Everybody's been really, really great about working with us. We've had several meetings making sure that we're all on board and we can collect the data that we need to. So I'll just kind of quickly take us through what we plan to do. So as we've talked about, our targeted population will be the elective colorectal cases, and these will be chosen by the colorectal surgeons at clinic. We do plan a great deal of staff education, and we're working on that now. Patient education, we've decided that this would probably be best done in a focused way rather than leaving it up to the individual clinics who have different levels of staff. They're very busy. So we are fortunate enough that Polly Smith is going to allow a nurse from the anesthesia clinic to do an ERAS class. So these patients will actually go there, they'll sit down with a nurse who will do one-to-one education, both verbally and provide some handouts. And we've worked on that, getting that down to a 6th grade level, reading level. We will also have a YouTube video link for those patients that maybe for some reason can't get there. There will have to be some education in the clinic, and then they can go home and watch this YouTube video. We do plan to track our processes and outcome metrics. As Dr. Dow pointed out, it's going to be important for us to track compliance, and as we track compliance, hopefully we'll see that our outcomes improve. And this will be in conjunction with the colon bundle that we're already working on and tracking. We'll have monthly multidisciplinary meetings to review all of this data and share it with everyone, and ongoing education, as you might guess, and feedback. So this is a really busy slide, and I'm not going to go through it in any detail, but this is our bundle from the pre-op clinic all the way through holding, intra-op, post-op. As you can see in the pre-op clinic, we're talking about optimizing patients. We've talked about that, and the only other thing I'll add is we're going to look at the strong for surgery recommendations so that we can make sure that the patients are as well as they can be before coming in for the surgery. So we know some of our anticipated challenges, as you've heard, and we've hopefully come up with some ways to intervene. So we know we need to clearly identify these patients. The nursing staff has asked, how are we going to know who's an ERAS patient? So they should be identified in the clinic. We are updating the 92 form so that can be flagged there, and when they come in, there'll be a pre-op order set that will be used. And then in handoff, this has to occur in handoff, that this is an ERAS patient so that everyone has that mindset of, we're going to be getting this patient up tonight, we're going to be giving them clear liquids, they really need to be up, activity. We know that moving away from our traditional thought, as Dr. Dow talked about, like MPO status, bed rest, NG tube drains, this is all going to be a little bit different, so we know that that will be a challenge for us. I think providing clear expectations and encouraging patients and their family is going to be a big point, and Dr. Ramos pointed out to me that it's really going to be a big part of the patient to participate with us and be ready to go. So getting started, we anticipate rollout probably mid-October. Right now we're planning staff education, and our anesthesia and surgeon champions are going to work with us on that. Patient education is being finalized now. We do have sunrise order sets. We have a pre-op order set and a post-op order set, which gets to the standardization. Everything's there. And obviously you have the ability to change it, but we'd like to try and stay on the pathway as much as possible. And we are updating the 92 form, as I said, to be able to identify which patients are ERAS as they come from the clinic. So with that, we're happy to take any questions or any comments.
Questions for the team?
From the anesthesia perspective, for your tap blocks and whatnot, are those uniformly y'all are going to be using liposomal bupivacaine or not necessarily? Can you speak to that?
I would like to be. You know, we've had an availability issue for providers that I've done it with. I've kind of worked on that with pharmacy to have it more available. Anytime I do a tap block, I don't see the utility in doing it with anything other than liposomal bupivacaine. There's really not a difference if you're saying this is going to last you 6 to 8 hours afterward when you just infiltrate marcaine, versus when you say you'll get about 3 to 4 days of a little bit of surgical site pain control when you use liposomal bupivacaine. So my suggestion to my department will be to really only do tap blocks with Exparel.
Because, I mean, it should be, from now, it should be approved for all abdominal surgery cases and all inguinal hernia cases.
I believe it will be, but, you know, through the P&T committee, we've worked to get Exparel approved for tap blocks by anesthesiologists. So really, it's just going to be any